Good morning, Sad.
So, well, thank you very much for sparing some time out. I just was waiting for us to be connected before I could formally introduce you to everybody here, and then also we'll give you a brief introduction of those here. Dr. Shrisha Heber, friends, he's a consultant gastroenterologist and a therapeutic endoscopist. He's endoscopy clinical lead, director of Stokes hands-on endoscopy uh, course center, which is one of the main leading centers of endoscopy, especially ERCP training, probably one of the oldest, if I'm not wrong. Uh, Royal Stoke University Hospitals, North Midlands, um, and Shrisha, welcome. Thank you so much. Early hours there in UK. We are on the third day of our course here.
Nice.
I would like to introduce two of our faculty. I'll start with Muhammad Khalid Hassan, who's working in Center of Interventional Endoscopy CIA in Orlando, Florida, which in itself is one of the best units in the world. And Khalid is like a younger brother to me, and one of the best endoscopists that I have seen working.
Excellent.
And an excellent overall. I mean, it's not just EUS, ERCP, and a wonderful person. He's been with us. This is his fifth or sixth course. We were debating. We're not sure. This is
Okay.
this is our seventh course.
Right.
I have Dr. Mustafa Arai, who comes from University of San Francisco, and who's again the head of their training, advanced endoscopy training, and again a very accomplished EUS, ERCP, and advanced endoscopy person, a wonderful, one of the most humble and polite persons I've come across, and an excellent endoscopist. So those are the two faculties other than myself, and I have my colleagues, Professor Shehryar and Professor Sajda, who are part of our unit here. And then we have the delegates who are here, 5 of them who are hands-on from different parts of the country, and then 2 are observers, and then our own, some of our own faculty members. Srish, what I wanted you to tell us is about the role of this basic hands-on course, the concept that you have in your unit, and how what is the role of that in developing ERCP training for those who are interested when they start their training. What role does it play, and is it something that's kind of mandatory there yet, like the colonoscopy hands-on, or not? And how do you see the role of that? Okay.
Yeah. Thanks, sir. Thanks for the invitation. And yeah, so the ERCP course in Stoke has been going on now since 1988. This was conceived by Dr. Jonathan Green, who's the head of the unit here. And since then, it has gone leaps and bounds as far as the ERCP course is concerned. At the moment, we're still in the process of getting ERCP accreditation, as what the process is required, but we still don't have a formalized one. So in that sense, it is still not mandated that every trainee should be doing this course, but is kind of accepted that if you're doing an ERCP training, you should do some hands-on course like this. And then at the moment, we're the only one who's delivering the hands-on ERCP course in UK. There are a few, as you know, just the model courses which has been going around in UK, everywhere else. And I'm sure you have that model as well, which is just the course is done. Can you hear me?
Yeah, we can. We just had a slight issue. What I understood was that your center is the only center now doing the hands-on course?
Yes, yeah, the hands-on courses, yes.
Okay.
For the basic course, again, I said there are few centers where they're doing just the model courses, but we are the only one who are doing the hands-on courses. The advantage, yes, what model course is useful. It introduces the candidates to the concept of ERCP and what it involves. But as you know, as you've been doing the last couple of days, there is more to. There's so many manuals in ERCP, so many subtle things, which is so different. You don't get that experience with the hands-on course. So I think that kind of a breakdown of any steps while you're doing live, it just gets the candidates who have some exposure to ERCP to a very different level. You don't have evidence to say how much significant impact will make. I'm sure that you've done an ERCP course hands-on, like almost you've done about 55 ERCP, so you just got that experience suddenly. Because of 3 days of intense, we're having discussions, we're seeing people perform, the challenges they face, it's quite significant. So if I just take my own example, when I did my hands-on course, that was the first time I did like annulation. And then suddenly, for the next 50 or so, I just had confidence level goes up, technique goes up. In fact, you go back to the unit and start telling your trainers, probably this is what I learned, and then this is what they showed us, and in fact, your trainers might pick up as well. So hands-on course as a basic one is very useful. Yeah.
Okay, so what I understood, a few glitches with the sound, but what I understood is that you feel that hands-on courses has been very good, and in your personal example, the first cannulation that you did was on one of the hands-on course, Hare and Stoke.
No, it was actually at the time in Liverpool.
Liverpool. So it was probably Howard Smart.
Yes, with Howard Smart.
Okay.
At the time, both centers were doing it, but as you know, I'm sure you're doing a great job organizing these courses, and you know how difficult to organize these courses are, and especially the ERCP, find the right cases to be lined up for the course is a challenging task. So I think that's why different centers struggle to organize the hands-on courses, especially the ERCP.
Yeah, I could not agree with you more. The other thing I wanted to ask you was, well, it's very heartening to know that outside UK, and you know you're the only center in the UK, and we are probably the only center that we are aware of doing courses which actually follow the pattern that you have in UK. And we find for ourselves as faculty here, we find it very useful for ourselves. We get very good feedback from the candidates every time. And that's what actually keeps us going, and that's what encourages us to continue with this endeavor, which is not easy at all. Like you said, it's even slightly more difficult where I am sitting for many reasons that probably are not so applicable to you guys. What the curriculum of this course over the years, you've seen a change. There's a lot of change in the practice of ERCP as well. There are new modalities, new concepts that I've seen change over the last so many years that I've been involved in. So has the curriculum changed? What system, what basic structure of the course you have currently now?
So we have a 3-day model course, just like what you have done this time. And again, the first day, the full half a day where we have people who come for an ERCP course are already endoscopists. So they know how to do colonoscopy, they don't know how to do gastroscopy. So they know why they need to do ERCP. But as we all know that ERCP is lots about decision making, more than holding the scope first. And then there's so much of variations in the practice as well. So we approach a model wherein the first half a day, and we all as equals sit together in a group, we put some case together, and then through the cases we discuss about indications, contraindications, sedations, complications, everything, but they're all incorporated in cases. And when it is in a case format like that and having a group discussion, and that's have a more lasting impact on the candidates than you somebody just giving a lecture. So I think that has been very helpful. And again, as we all know that ERCP has moved quite a lot, is only therapeutic procedure now. MRCP, endoscopic ultrasound, has again made a significant impact. difference at how we manage these patients, which one to select. So all of that we have changed and incorporated into the training now. So again, it might be much different. Again, lots of this on what setup the centers have and what practice do you differs from what facilities you have. So we have to incorporate and have discussion based on that. Following that, at the half a day, then we go to the model, hands-on model for the next half a day. And then next 2 days is all live hands-on cases. We don't put too many cases. If you put too many cases, we have found that it actually doesn't help the candidate. We only put about 6 cases each day for the whole day, but there is lots of discussions in between. There is video cases. Every step is broken down in between. We have feedback in the group or the candidate. So I think that enriches the candidates than doing a half part of the many cases. So more cases doesn't actually add.
So just Khalid wants to talk.
So it's a 3-day course, and the first day really there is no hands-on as far as the patient is concerned, correct?
Yes.
And then the next 2 days it's hands-on and obviously discussion with that. So how many candidates usually are, and how many cases? I know as you mentioned that like goal is not to give them more cases. Goal is to just give them more exposure and a variety of cases. So, but having said that, how many candidates you take and how many cases they end up doing? If you have 6 cases for 2 days, total 12 cases, so maybe 3 candidates, 4 cases, or how does it work?
So it's 4 candidates, and they get about 3 cases each. But as you said, the variation, so we would have planned 10 cases, but 12 cases, but it might end up 10 cases, or sometimes end up 13 cases or something. But also with the hands-on case, what we also have with the ERCP is that they should have a kind of an objective just for every case. So you say, okay, you have a varied degrees of expertise which each candidate comes in beforehand. So if somebody is already comfortable in intubating to start with, so you said, okay, we'll not waste time with that. So I will intubate, get you to the ampulla. So if the objective for you is cannulating the ampulla, then in this case, your learning objective is to cannulate it. So we're not spending any more time, anything else. So I go as a trainer, go and park near the ampulla. And now, so that he has a focused training for the next half an hour, 45 minutes, whatever, try to cannulate the ampulla and do it. So again, our focus is that at that moment. But then as soon as the case, once they're cannulated, but if they've taken longer than 10, 15 minutes to cannulate, then take over. And then if they're going smoothly, then we let them continue. But what's important for the trainee is to understand that we have objective what we need to achieve. Because they feel, even that happens in a normal RCP training as well. So if you say that if you take over the case in between and then we have not discussed what you have taken beforehand, they feel dejected. They feel that they have not achieved something. But if you have an objective and say, this, your goal is not cannulation this time, your objective is to do a balloon draw. What's the technique of to learn more about what are the things, challenges you face. So in that case, if they are struggling to cannulate, we say we take over immediately, we cannulate and give it to you video spectrotomy, and now your focus is on balloon draw and things which you need to learn. So that kind of a focused training helps the trainees.
This is Mustafa here. What level of training have they already received when they're joining your course in terms of ERCP? What experience do they come in with?
It's quite varies for the basic. So again, we have one is a model training course. We also do that, which is a 2-day model training course where they have no hands-on, but that is to somebody who wants to be introduced about ERCP. Has never had any hands-on at all, who is probably just signed off gastroscopy and he feels I want to know something about ERCP. But then the next level is the basic ERCP course like this course, where they might dabble around 25, 50. They've tried a candidate, never succeeded, or even succeeded a few times. So we don't actually restrict any candidate to coming to the basic hands-on course. The next level we do is the upskilling course. This is for a 2-day course. It's for every ERCP. It could be a 20-year-old, a 20-year experience, somebody who's got a 5-year experience. What we say in this course is sharing good practice. We're not teaching anyone. We're getting a group of ERCPs together because we don't get a chance on a day-to-day practice to interact with anybody else regarding the practice. So 2 days of intense ERCP among the colleagues, and we are just a facilitator. But saying that, we can get lots of candidates coming in, and then obviously, as we know, we always learn from these courses. And then in this course, 2 days, straight away they start doing ERCPs, 12 cases, we get 6 candidates. But then we tell them beforehand in this course, this is not your center. It's not a failure if you don't do a complete procedure. We understand the challenges of that's very important for the candidate to know. But and then when we do that, in half an hour or so, any chance if you're not succeeding, we take over. Take over doesn't mean that it's your failure because it's just that it's not centered, you're not used to being online. And with that kind of setup, it's always get very good feedback and there's loads of discussion and it upskills the ERCPs.
Yeah, I'm really impressed with that concept. The only thing is that when you have some senior guys, how do you take the scope over? That is a very tricky thing. I am sure even more, maybe more here than even in UK, but I'm not sure. I mean, but it must be. You need special skills for that as well.
Yeah, I think to put the ground rules beforehand is what makes it easier. You say 45 minutes per case is in the course. If it is going beyond that, a local faculty will take over, and it's not a failure. It's just that we have to keep on carrying with it, and then so after 45 minutes, we all go back into the room, and then we have a discussion or something. But so if you put the ground rules, then people receive it very well.
Okay. Is there anyone who wants to ask a question? Well, there's some delegates.
I just want to question that what is the criteria for selection candidate on hands-on? Is there any criteria? If you select a candidate, whether he will become an observer or a hands-on candidate?
Okay, Prisha, one thing that we do differently from you is that we allow observers. You see, and so because we take 5 candidates, and we were doing 4 days. It was a little hectic and tiring. So we decided this year that we would reduce it to 3 days and try and do away with a lot of lectures. The point that was being made here is: do you have any special any criteria for selecting candidates for your hands-on course? Number one. And as I said, observers here are very similar to what you probably do for the new candidates. You just bring them and they get a chance to know what ERCP is about and learn and see how it's being done. That's what we do. So any criteria you have?
No, I think the only criteria for selection for a candidate is that we say a hands-on course, they have to demonstrate that they have got a training list lined up for them. So there's no point they come to the course and then saying that I'm going to do ERCP, and then for the next year or so, they have no access to the training list. So it's not useful for the trainee, and it's not useful for the time we have invested on. So the only thing they have to demonstrate is that for the next year, they have a dedicated training list, and then they have to get a letter from the trainer saying that that is offered. Apart from that, we have no selection criteria whether they've done 25 or 20 or so.
Okay, that's that I think is something that we do too, because there's no point training if you're not going to go back and use it. Anyone else? Is there anyone else who wants to ask any questions? No. Okay. A couple of things. The collaboration
Yeah.
and evaluation of what we do. And I think, one of the things I discussed with you was because our course is very similar, except that it's kind of an international thing. This time we don't have Dr. Waqar Ahmed from Manchester. Otherwise, it's US, UK, and Pakistan. So that's a slight difference because we bring different practices here and obviously different continents really. Yeah. And we learn a lot from each other. We enjoy it. I'm sure your faculty enjoys doing it. It's a hard work. Where have you evaluated formally? I know Stoke's been doing this. Jonathan Green has been doing it even when I was in UK. I think that's just about the time when the first course was done, as I left UK, or just about that time. Have this been evaluated in terms of response from the candidates, or how it has actually helped them going back into the training of ERCP? Do we have any objective evidence of that? Have you looked at it?
Yeah, we've been thinking about that, but I think if you can help and see how we, as a collaboration, we know what's the best way of doing that. As you know, it's very difficult to objectively do that. The only thing which we have looked at is the safety aspect of it. People have concern whether this having a course of a hands-on nature on an ERCP. People have never done ERCPs, only done 20. Whether it's safe, are we doing the right thing for the patient? So we looked at about 500 ERCPs which have been scoped in the ERCP course, and we just said that it is safe and that they're meeting all the criteria. I think that's the only thing which we can objectively test at the moment. But we've thought about it, but find it difficult to objectively say what has made a difference in each candidate, because each one's experience is different. They take lots of subtle things in, but how much has really made a difference translated? For example, I get a feedback after the upskilling course mainly, that they're not confident with fistulotomy, they've never done before, and so on. But then I get an email a week later saying that, after the course, now I've done 2 fistulotomies. Now I understand the anatomy more. These are even senior trainees, or the senior trainers. So that kind of a feedback we get, this is something I'm doing differently, but I don't know how much more objectively we can test that.
Yeah, I think that is one of the problems, because it's becoming more and more evidence-based world. So when I just was asking myself, are we really making a difference in the lives of ERCP lives of those who come to our course? And it would be nice of somehow knowing that what we are doing is actually objectively benefiting them, but we've actually ourselves not been able to. Yeah, we get the feedback, but verbal feedback we get from almost everybody that it has made a big difference to them, both in colonoscopy and ERCP courses. But I can share that so far we have done 150 and plus, maybe 160 plus cases during the courses that we have done. We've got another 6 or 8 lined up today. So of all those cases, we've not had anything. Firstly, we've literally not had any failures, and the other thing is we've not encountered any major complication. We obviously we select those patients carefully, because we try and bring what appear to be simple cases rather than more complex cases in courses, and we try not to do difficult cases here in the course. But sometimes you get stuck. You can't. You think this is going to be something, and turns out to be something else. So the last thing, I've taken a lot of your time, thank you once again for taking time out, is that we would obviously look for some kind of collaboration and continued collaboration with you now, as I discussed last week. And we could probably improve our course even more, and maybe share our experience with you, and maybe there are things that may help you as well. So we'll continue. We look forward to continued collaboration from this day on, really.
Yeah. Thank you very much. I think as I discussed, I think teaching and training is something which we share. That's the only way we can enrich ourselves, and totally up for that. But just the last point about when you say about the making the difference. But one of the courses which definitely makes a significant difference is a trainer. So in the saying one can they and they go away, but if you train the trainer coach and then that trainer who has got our structure as how to train. Now, the number of candidates, trainees who goes through that trainer, they're all enriched. So I think that the trainer ERCP has made significant difference. Again, it's very difficult to do a research on that as to how many ERCPs training take to get trained by the trainer beforehand, and now after the course, how soon they're learning this technique. It's very difficult to objectively do that. But we know from experience that with the trainer who's been gone through that, they've done quite significantly in the trainees after that.
No, I couldn't agree with you more. I mean, train the trainers course is something that we've been wanting to do, but it's just that how much can one do and accommodate within a year is a big problem. And obviously, faculty coming from overseas is not always easy. It's really difficult for these guys. They've traveled from US for a few days to help us out with ERCP. We start our EUS course tomorrow. It's again a 3-day course, similar model. This time we have actually tried to be too brave to have 2 back-to-back courses. We'll let you know how we feel after the end of the second course, but I'm pretty sure we'll be all completely drained out. Shrish, it remains for me to thank you, and I look forward to hopefully seeing you in one of our courses here, and requesting you to make a trip and evaluate actually us and our course, and tell us if we how we can improve it more, bring it in line with what you guys are doing, which is a great job, and that also will reassure us. So look forward to our hopefully long-term relationship in this training, training objectives that we have for hopefully the future generation of endoscopists.
No, definitely, and look forward to that, because I said I'm sure I'll learn quite a lot when I come there. That's always useful. Yeah, thank you.
Thank you. And did I tell you that this course is actually live on Facebook?
Oh, is it? Oh, I didn't know that.
Yeah, no, it's live on Facebook. So it's the ERCP course and 7th ERCP course. If you go on Facebook, you can actually see the whole course. In fact, you can also see the last 2 days, if you want to see any part of it. Thank you once again, Srish, and have a great day, and look forward to seeing you.
Okay. What page is it on, by the way?
It's Facebook. It's 7th ERCP course, and it's by Wilson, Wilson, Wilson.
Okay.
So if you go on Facebook and put ERCP course, it'll bring you on to 7th ERCP course, and it'll say Wilson something, and that's Wilson Learning. Wilson Learning Online. Okay.
Okay. Thank you. Nice to meet you all. Thank you.
Take care. Thank you once again. Thank you.
Okay.